আমি শুরু করলাম স্যার।
Yes, শুরু করো।
Bismillahirrahmanirrahim. I welcome you all to the virtual academic program of Oncology Club. And in the era of social distancing, we are trying to keep socially connected with this initiative. And today, this is a session that we have been running for the last 3 months, that how should I treat my patient following evidence-based medicine. We have finished the breast cancer session. Now we have started the lung cancer session today. And today we have our faculty is Dr. Mostofa Aziz Sumon. He is the assistant professor in the Department of Radiation Oncology, Gurmit General Hospital. And he will be talking on mutation analysis of lung cancer from oncologist point of view. And to introduce him, what I can say that he is one of the most promising oncologists that I have seen, and we expect that very soon he will be crossing us and creating a milestone in the field of oncology in our country. Today we are having a new guest, overseas guest, Dr. Colonel Retired Anurag Mehta. He is the Director of Department of Laboratory and Transfusion Services and Director of Research, and he of Rajiv Gandhi Cancer Institute, Delhi, and also he is the Editor-in-Chief of Journal of Current Oncology. And Dr. Mehta is running probably one of the largest molecular lab, hospital institute-based molecular lab, if I'm not wrong, in India. And Rajiv Gandhi is a very respected institute for their academic activities. We will be expecting John Conibeer and Farid very shortly to join us. And as usual, we are always blessed to have our president and our patron, Professor M.A. Hai, whose presence is an inspiration for us. And sir, thank you for being with us. And now I will request our Professor M.A. Hai, sir, to say a few words to start the program format. Professor M.A. Hai, sir.
Thank you, Kamal. Bismillahirrahmanirrahim. Heartfelt thanks, gratitude to participants, particular faculties from abroad, Dr. Anurag Mehta from Delhi, Dr. Sheikh Farid Ahmed, and Dr. John Conibeer from London. And today our speaker is Mostofa Sumon. We'll be talking on mutation analysis of lung cancer from oncologist point of view. Okay, Sumon, start now.
Yes, sir. Thank you, sir. So just for housekeeping announcement, our program will be for 90 minutes. Our presentation will be 15 to 20 minutes. Then we will be expecting some comments and the question and answer. And this today we don't have a case, but still we have some discussions. And then we will do the vote of thanks. Normally we treat all the foreign and local presenter and participant of the assistant professor as faculty, postgraduate students, physician and PG students who will be the participants. We expect that the question will mostly come from the participants, but anybody is open to do a question, and there will be a quiz that will be open for all. We request to put the question in the chat box so that we can bring up during a discussion. And in addition, what I want to say today, that after the presentation of Dr. Mostofa, as we have a faculty, Dr. Anurag Mehta, who is an expert in this field, I will request all our participants to ask question to Dr. Mehta so that we can have a good thought exchange with him, because molecular profiling is a very important but not a very well practiced issue still in our country and community, but it is a very important factor. So that's why we requested him, and we are so grateful he is with us, and we are expecting our one of the local faculty, Colonel Joinul Islam, to join with us. So we will be expecting, in addition to Dr. Mostofa, that both of them will be enriching us with their comments. Now may I request Dr. Mostofa to start the presentation.
Let me share my slide first. Is it okay?
Yeah.
Thank you, Kamal Bhai, for such a wonderful introduction, though I'm not sure whether I am really capable for those words. But the assignment which was given to me is the analysis of lung cancer from on view. Here you see, I have red marked this area, this oncologist, as because probably many of us heard thousands of words several times regarding these topics. But most of the times, the speakers were pathology domain. But we have to admit that the perspective, the objective from a pathologist and the clinicians are quite different. So in the next few minutes, I will try to cover these topics, the mutation analysis from oncologists, that means the clinician's point of view. So come to this gentleman. His name is Sanju. He was a famous Chinese general and he was known as the maestro of war tactics. He found a very interesting way to win a war. He used to believe in two principles: know your enemy, know yourself. So these same tactics will be applied here in the war against lung cancer. We need to know our enemies, that is the driver mutations, and at the same time, we need to know our strains, drugs that acts against these driver mutations. So let's see what is our enemies. So definitely, we are talking about the genes and genetics. So where we could find genes? Definitely not in the lamp of Aladdin's. So here you can see that this is the structure, that is the chromosome, which is nothing but the condensed filaments of the DNA. So this is the part of the DNA which can capable of synthesis of functional protein. This can be named as a gene. So in our next few slides, this gene will be the topic of discussions. So let's have a recap. All we know that every cells we have 46 chromosomes. Out of 2, there are 44. The 2 are sex chromosome and the rest are for different actions of the bodies. So you can see that the chromosome, have I already mentioned, it is nothing but the condensation of the DNA filaments. So ultimately, this is the DNA. So here comes the DNA double helix structures, and the structural block is called the nucleotide. And a nucleotide is formed with a phosphate and a pentose sugar and definitely a nitrogenous base. And there are 2 types of base pairs, purine and pyrimidines, as you already know, that the purine, adenine and guanine, and this counterpart thymine and cytosine. So here you can see this nucleotide forms a series of cascades, and these 2 cascades are bound together with the hydrogenous bond, which ultimately forms these double helical DNA structures. So in the structures, if a sequence of this nucleotide are capable of synthesis of protein, that area or the part of the DNA is mentioned as the gene. So probably we have got a recap idea what is genes and where it lies, where it remains. Now come. So we need to find out the genes, but from where we get this information? So definitely we need a lab. But keep it in mind that all labs are not really prepared for this sorts of investigations. So according to NCCN 2020 recommendations, if we want to send a samples for a genetic mutation test, that lab should have minimum CLIA accreditation. So keep in mind before giving a requisition slip that whether this lab have this CLIA accreditation or not. Now, assume that we have got a lab that is accredited, that is validated, that is standard one. But now the question will arise. What would be the samples? Will it be the tissue? Will it be the cytology specimen? Will it be the blood, sputum, pleural fluid? So as per this recommendation for the genetic mutation analysis, we need formalin fixed paraffin embedded tissues. That is the gold standard. But we have to admit that getting a tissue from lung is not a very easy task. So different institutes try differently. Some some centers tried with this cell blocks, but yet it is not FDA approved. So till date, the formalin fixed paraffin embedded tissue would be the gold standard. But what about the liquid biopsy that is very popular here in Bangladesh? As per this recommendation, the liquid biopsy should not be considered as the alternative of the histologic tissue diagnosis. Though it is very specific, but its false negative rate is quite high. Not only that, its report still is not validated. But sometimes we have to do with this liquid biopsy. And those who are very unfit for any kind of invasive tissue processing, so these are the candidates whom we can consider this liquid biopsy. But keep in mind that initial diagnosis should be done on a histopathological diagnosis. So from this slide, we should keep these things in mind that the lab should have a standard level of accreditation. We need to send this tissue or a good pathological report, or molecular pathological report. Till date, cell blocks and liquid biopsy is not an alternative for these tissue samples. So we should focus on this tissue. Now, consider we have got a lab, we have got tissue. Now, by which method we are going to get these results? What are the tests? So you can see these are some tests that we are very familiar with this terminology: PCR, FISH, IAC, and the hot cake next genome sequencing. So if you know your mutation, that is single mutation that is very well known in this context, if you want to find out a single mutation, you can use this methodology: PCR, FISH, IAC. Each method has some pros and cons that we will discuss later on. But if you want to know a different type of mutation at the same time, you can consider this multiplex test or this NGS. So if you know your mutations, if you want to find out a single type of mutation, you could consider PCR, you could consider FISH, you could consider immunohistochemistry. If you want to find out a different type of mutations, whether known or unknown, you need this NGS. So during the last decades, with the invent of these targets, as well as the enrichment of our armamentarium with these targeted drugs, what statistics changed over the decades? Let's see. You can see in 2010, for the advanced stage adenocarcinoma, the main weapons were chemotherapy. You could see the green zone is the chemotherapy. And there was a narrow strip, means that the availability or the scope of targeted therapy. It was in 2010. But come to 2020, you can see that this area is quite larger in this 2020. And unfortunately, there is no space for this green, that is the chemotherapy. It has got no space in the first phase. Its space was in the second phase. So we could learn that now in the year of 2020, targeted therapy has a very important role, particularly for advanced adenocarcinoma. So we have got a number of mutations, particularly in lung. So whether we have to check one by one, we have to check a number of mutations. Is it possible? Definitely the answer is no. So what are the main mutations that we really need to check in case of metastatic or advanced non-small cell lung cancer? As per the latest ESME clinical practice guidelines, we need to check at least these 4 mutations. That is the EGFR, AL, ROS, and BRAF mutations. And if all these tests come negatives, then we should check PDLR mutation. Come to the squamous cell variety. Even in squamous, we can check some of this group, those who are non-smoker or light smoker, those whose histopathological diagnosis are squamous, or the clinical diagnosis is not very clear in this part of this group, we can even this squamous cell carcinoma, we can check the molecular investigation. Now, as per the NCCN guidelines, ESMO guidelines, you can see there are 5 tests we need to check. That is the 5 tests that the EGFR, ALK, ROS, BRAF, and PD-L1 mutations. From where we have got these 5 mutations, you can see there is the data that the prevalence of the genetic mutations among the lung cancer group. Most prevalent EGFR mutations is EGFR. The highest incidence occurs here in the Asia, that is the 40 to 55%. In after EGFR, you can see that the most prevalent mutations KRAS, and after that ALK, ROS, and BRAF. But the KRAS right now is not in our point of interest, as because it is not considered as a clinical entity, or we don't have any modalities to combat this KRAS. So we are now focused this EGFR, ALK, ROS, and BRAF issues. So we have to check these 5 tests as must: EGFR, ALK, ROS, BRAF, and if we don't have got any of these mutations, we need to think about PD-L1 expression. After that, if you have enough opportunities, we could see these additional tests that the KRAS, RAT, MET, HER2, these are going to give some prognostic information. So come to our first mutation, that is the epidermal growth factor receptor. So here is the epidermal growth factor receptor, which is nothing but a protein. It is a transmembrane protein. You can see there is a extramembrane, intramembrane part. So it is growth factor receptor dependent. So when a growth factor attaches with it, it initiates a signal which can activate this RAS, PI3 kinase chain, or JAK-STAT pathway. Ultimately, it causes cell proliferation. So it is growth factor receptor dependent. But what happens when it is mutated? When it is mutated, it gets an autonomy. So it don't need any receptor binding. So without any receptor, without any growth factor, it continuously produces the signal ultimately which causes this cell proliferation or this chemoregenesis. So this is a kind of somatic mutation. It mainly occurs in the carcinoma, non-smoker, women, and Asian population. But there is a trend in Bangladesh to consider these criteria for giving these targeted drugs. As per the NCCN guidelines or ESMO guidelines, we should not use this criteria for prescribing CKI. Rather, we need a black and white paper for a definite type of mutations. So we should not prescribe based on this clinical information only. Now come to this mutation in details. So you can see, so where is the gene lies that is responsible for this EGFR? You could see that is the chromosome number 7. So we already know that there are 46 number of chromosome, and it is named numerically 1, 2, 3, 4, and 7. So the EGFR gene lies in the 7th chromosome, and you could see we can name it differently. The long arm, short arm. The short arm is mentioned as P, and the long arm is written as Q. I am not going in details. Even in this location, the number of position is made by some numerical terms, exons and introns. You can see the 18 to 21 exons locations are the area for this EGFR gene mutation. So when any mutation occurs in the 19 exons, we call 19 exons mutation. When it is occurs in 18, it's 18 mutations. So all the mutations are named based on these locations. So let's see what are the mutations that commonly placed in this location. Very popular 19 deletion, exon 19 deletion, that means the deletion occurs in the 19th place. Exon 21, that means it occurs in here 21 L858R. Exon 19 insertion here occurs, exon 20 here. So the mutations named as the location of the exons, and the T790 mutation. We are very popular with these two mutations, exon 19 and exon 21 L858R, but we are not as much familiar with these exon 19 insertions. Exon 19 insertions till date is a non-functional mutations, but some papers are ongoing. They are trying to find out whether the gefitinib has any role on these mutations. But we need to find out that exon 20 insertions, because if 20 insertion is there, these insertions resistant to clinically achievable level of TKI. That means it resists the TKI to get a level of clinical significance in the blood. It resists. So when exon 20 is there, you could assume that the TKI is going to respond poorly. So we could check out these mutations as well as all these things too. Here comes this T790 mutations. It is acquired mutations. Most of the patients, those who are initially mutated with this 19 and 20, 21, having TKI, unfortunately in 9 or 12 months, most of them develop resistance. And T790 mutations is the culprit for these mutations. So this is acquired type of mutations. Not only that, sometimes we can find some germline mutations regarding this T790 mutations. If germline mutation is there, we need to consider the familial lung cancer predisposition. So these are in short the EGFR mutations panels. You can see that exon 19, 21, 20 insertions, 20, and T7. These are the common actionable mutations right now. So here I am going in details that what is the EGFR mutations. You can see that the 19 deletions. I have already mentioned this place that the 19 mutations occurs here in this 7th chromosome in this location in 18, 19 exons. But actually what happens there? You can see that the nucleotide sequence, this is without mutation. But when this deletion occurs, you could see a part of this nucleotide is wiped out, that is deleted. So it's named as a deletion mutations. Come to 21 L858R mutation. It occurs in the 21 position. Here no deletion, it is substitution. That is you can see that L858 position, that the mutation lysine, it is replaced by arginine. So this is a substitution. That's why it is called a substitution mutation. Happens in the 21 L85, L for lysine and R for arginine. The similar type of mutation occurs in the T790 location in the 79. It is also a substitution type mutations. So we have got the EGFR mutations. Now come to the clinical questions. How could we find these mutations? So according to the CAP ISLC guidelines for EGFR mutation find out, we have to check by PCR methods or by targeted NGS. So we have got different type of tests, but among these, we have to check these mutations with either PCR or by targeted NGS. Now come to the second most prevalent mutations, ALK. So ALK is a fusion mutation. Here you can see it happens in the number of chromosome 2. You could see the green and purple color here. What happens when the mutation occurs? You can see that the green comes down and purple comes out, up. So there is inversion occurs, and after the inversion, there is a fusion occurs. That's why it calls the fusion gene mutations. And most commonly, the fusion occurs with the ALK kinase to EML4. So that's why EML4 ALK fusion protein is called the most prevalent ALK fusion genes. But fortunately, the EGFR and KRAS mutation are mutually exclusive. Means if you have EGFR mutations, there is less probability that you are going to have these KRAS mutations. So this is the type of fusion gene mutation. So what are the tests for ALK mutations? As there is a fusion gene mutation, we need to keep it in mind that any kind of fusion mutation, PCR has some limitations. So the golden test for this type of fusion mutation is the FISH. You could check it by some immunohistochemistry, but till date the guidelines approve immunohistochemistry for a screening purpose. For a clinically application or for giving for TKI, we need to pre-confirm it by FISH. Come to the ROS. It is also a fusion gene. I am not going in details. So as it is a fusion genes, you could find out that here is the most fusion occurs with the CD74 as like the ALK fusion. The CD74 is the most predominant fusion gene mutations. So as it is a fusion genes, Probably we have know what should be the answer for the test. Yes, it is fish. So for Ross genes, we need to check by the fish investigations. Now come to the BRAF, last four mutations that is more clinically important. BRAF mutation is one kind of substitution mutation. And you could see that most common mutation is the V600E. And from BRAF mutations, as it is a substitution type of mutations like that of L858R, we could check by this RT-PCR method. So these are the four most important investigations that we must check. But beside this, some other additional mutations that are coming in front that probably might have some clinical implications. So we need to check if additional information we really need, but this is not must. This is good to know. So these are the red fusion gene. I'm not going in details at the fusion genes. We need to check it by fish. Intract is another upcoming very important mutations, intract mutations. So intract mutations is also a fusion genes. So we should find out this is by fish. Mate is an amplification test, and amplification mutations, amplification. So we need to check it by fish. So come to the next genome sequencing, that is very hot and popular topics. You could see that in every test, whether there is a PCR or fish is capable, but every time you see that the bottom line is for NGS. So NGS is the upcoming future of these genetic mutations. But why we need this NGS? NGS we need as because if you know the mutations, if you know the specific mutations, then the PCR features certain roles. But for in uncommon or unknown mutations, they have some limitations. Not only that, sometimes PCR can find some types of mutations, that is the deletion or insertions, but it is not fit for fusion genes. So in order to get a report by different type of mutations, next genome sequence is the ultimate answer. But till date, NGS is not authorized by any of the endorsed society. Just few weeks or last week, ESMO has endorsed a paper that has given some authority for using this NGS if price consideration is not an issue or if price consideration is almost the same. So NGS is really important topics. I think Professor Mehta should give us a light regarding these important hot topics. I am not going into details with these topics. So come to the recommendations as per the ESMO. EGFR mutation test should have coverage at least from 18 to 21 mutations. So we need not to forget, we should not forget the 20 insertions. ALK translation should be tested by fish. ROS mutation should be by fish, and NGS tests are preferable. So I am at my last slides. So here in my summary, I just want to highlight that if you get adenocarcinoma patient, advanced adenocarcinoma patient, please try to find out these molecular targets, at least this first 4 before giving any source of chemotherapy. Because with this mutation, that ALK is the highest good prognostic mutation, we could find even a 4 years overall survival. Even with EGFR, we could find around 3.5 years with a very less toxicity. So it's our request to our colleagues, please try to find out these mutations and with a valid tissue, with a valid pathology lab, and treat your patient with the most dynamic, with the most specific, with the less toxic modality. Thank you. Thank you all.
Thank you, Dr. Mustafa. Now I think we can first hear some comments about the presentation, then we go to the question and answer. May I request Dr. Mehta to make some comments?
So, first of all, let me, compliment Dr. Mustafa for giving us a brief overview, but a very basic insight into the molecular drivers that are actionable in lung cancer. And I have some comments, and I will actually start with the biopsy. So my first comment is that all small biopsies, because these are advanced lung cancers and you will only have a biopsy, all small biopsies must be classified histologically based upon 2015 WHO classification. And this allows you to classify small biopsies into three categories. The first category is adenocarcinoma or favor adenocarcinoma. The second category is squamous carcinoma. And third category is NSCC, non-small cell carcinoma, not otherwise specified. And all cases of non-small cell carcinoma, adenocarcinoma, and non-small cell carcinoma, not otherwise specified carcinoma, must proceed for biomarker testing. The squamous carcinoma need not proceed for biomarker testing because there are no actionable drug. However, because a small biopsy may fail to sample the areas where adenocarcinoma is present, so in those cases where the individual is young, he's not a never smoker, a female patient, or he's from Asian descent, then these are the situations where a squamous carcinoma can also be taken up for biomarker testing. Now, till April 2020, as Dr. Mustafa has told us, there were five molecular biomarkers. So we had to test for ELK, EGFR, which is prevalent in about 32% cases in our part of the continent, ELK around 7 to 8%, ROS1, BRAF. These were four molecular biomarkers that were, tier 1. In addition, there were two biomarkers, the PDL1 for immuno-oncology practice for treatment with immune checkpoint inhibitor that we need to test. And we could also test for anti-RK fusions, because anti-RK fusions are agnostic markers in all solid tumors, irrespective of the site of the tumor. So anti-RK fusion also were tier 1 biomarkers for testing by laboratory. In addition, we all know that MSI is also an agonistic biomarker, though MSI happens just in about 2% of the cases of lung cancer, so you could also test for MSI. But between April 2020 to August 2020, three biomarkers have had the FDA approval. The first biomarker to receive FDA approval was RAT mutation, a RAT fusion rearrangement, for which a new drug, selpercatinib, has been approved by FDA. So this for this selpercatinib, we need to, this is a tier 1 rearrangement now. So we need to test these also. The other one is MET exon 14 skipping mutation. Now that MET exon 14 skipping mutation is different from MET amplification. Here, one exon 14 is not transcribed into messenger RNA, it is lost. And when this exon 14 is lost, the MET protein does not undergo the biological decay that it should undergo. And as a result, it constantly continues to transmit signal downstream, resulting in carcinogenic process, or drives the carcinogenesis. So the MET exon 14 skipping mutation, a new drug called capmatinib has been approved. I think it was approved on 19th of June 2020. And lastly, another agnostic marker has been added, which is the tumor mutation burden. So any solid tumor where there is a mutation burden of more than 10 or more, can also be used for immune checkpoint inhibition. So these are now tier 1 mutations and must be tested. So in nutshell, we can say that there are about 8 or 9 markers, including the molecular biomarkers and the biomarkers for immune checkpoint inhibition, assays. So single gene assays are not tissue friendly, they are not tissue proficient, and the tissue will become an issue if we have to test for all of them by single gene assays. So there NGS is required. But the NGS has a problem of turnaround time, because NGS reports are usually available in in 3 weeks' time, while the single gene assays, for example, EGFR, L-cross, you can probably do it in 3 to 4 days' time. In case, you know, you have to do fish again, and BRAF V600E. So single gene assays, in our practice, we do single gene assays for EGFR, ALK fusion, ROS1 fusion, and BRAF V600E. And we also do PDL1 testing upfront as a reflex testing. And if we find no biomolecular, in most cases, we proceed to do NGS for broad testing. One point I will like to highlight that once you have done the first year testing of EGFR, L-cross, and BRAF V600E and PDL1, and if PDL1 is found positive and all other biomarkers are negative, don't rush to use immuno-oncotherapy. You shall wait for immuno-oncotherapy once you have exhausted testing for all biomarkers, because it has been seen that patients who are positive for biomarkers, molecular biomarkers, don't respond to immune checkpoint inhibitors. Usually the PDL1 report will be available in 2 days, and the other biomarkers report will become available 3, 4, 5 days. So don't jump the gun. Don't start treating on the basis of PDL1 expression. Wait for all the biomarker reports to be available. And if all the biomarkers are negative, then only proceed to use the immune checkpoint inhibitors. So I think that is in nutshell what I will want to say. I actually am an advocate of next generation sequencing, but turnaround time is a problem. But if we all start using NGS, if we can optimally utilize the chip or the flow cells, the cost can come down and the turnaround time can be reduced to 10 business days. And then I guess, you know, our practice for lung cancer can really improve by leaps and bounds.
Thank you, Dr. Mehta. We will be coming back to you quite a few times again, I'm sure. But thanks for the immediate comments. I see one of my friend, Dr. Jainul Islam from Armed Forces to the Pathology. Would you mind to make few comments? I'm sure you have catched up with the last part of the presentation of Dr. Mostofa. Jainul.
Thank you, Dr. Tal. Yes. Can you hear?
Yeah, please.
Can you hear me?
Yes, we can. Please proceed. Yes, Dr.
Can you hear me?
We can hear you, please. You can proceed.
In fact,
Please unmute yourself. Please unmute.
hello.
Yeah, now it's okay. Joinul, we cannot hear you. Maybe we come to you again later on. In the meantime, we have some questions.
I think
Yes. We come to you. After a few minutes. I think you are having some problem with the line. Sound is not very clear. Okay, so we have some questions here. We have a question from Dr. Arman Raza Chaudhary. So, Dr. Arman, would you like to ask the question? I will ask you to ask the question. If Mostofa answers first, then if required, Dr. Mehta will supplement. Dr. Arman.
Thank you, Dr. Kamal Bhai. So my question was, so what is the clinical benefit of testing BRAF mutation in lung cancer? And my another question was, when should we advise NGS in case of lung cancer? And how should we interpret PD-L1 report in case of our clinical, in terms of our clinical practice? These are my questions. Thank you.
Who should answer, me or Professor Mehta?
You can mutually decide.
Okay,
As Professor Mehta is there, I think he is the authority.
Okay, sir. Okay, sir. Can you please respond?
So BRAF, as far as the BRAF mutations are concerned, there are several BRAF mutations, but the one which is of importance to us is BRAF V600E, where at the 600 amino acid, the valine has changed for a is the mutation which is actionable, which are called dabrafenib combined with trametinib, and it has shown us overall the message number 2 was, when shall you apply for NGS? As a matter of fact, the current practice in the Western world is to do NGS upfront without doing any other single gene assay. But in countries like ours, I think the best practice will be to look for highly prevalent mutations, for example, EGFR, L cross, and BRAF V600E as a single gene assays, and PDL1. And if we do not find actionable mutations in these, then we shall proceed to do the NGS. NGS is highly tissue proficient. 8 sections, 4 sections for DNA and 4 sections for RNA can give us all information. And there are various nice panels available in NGS which can tell you about all the current actionable mutations. Your third question was, what do you make out of PDL1 report? Now remember, we have 3 drugs which are approved for first line use in advanced lung cancer. The one is pembrolizumab, the second is atezolizumab, either in combination with chemotherapy or standalone, and a combination of nivo and ipi. So first of all, I think it's the responsibility of the physician to inform the pathologist or his lab which of these monoclonal antibody or immune checkpoint inhibitor he or she is going to use. If one is planning to use pembrolizumab, then the laboratory is expected to test it by an assay which requires a monoclonal antibody called 22C3. If one is going to use atezo, then one needs to test it with SP142. And if one is required to use nivo plus EP, then the PDL1 has to be tested by 28.8 clone. Now, all these 3 assays are not equivalent. They are specific for the immune checkpoint inhibitor that you have to use. And therefore, there should be a clear understanding between the lab and the oncophysician that what is the immune checkpoint inhibitor that he or she is likely to use, and accordingly the lab should perform. Now for Pembro, you require 1 to 50%, more than 1% positivity of the tumor cells to use pembrolizumab in first line. For Atezo, you require more than 50% tumor cells or more than 10% tumor infiltrating tumor infiltrating immune cells occupying more than 10% of the viable tumor areas. And for EP, you require 1% positivity with the 28.8 of the tumor cells. So PDL1 should not be, like just write PDL1, specify which antibody, monoclonal antibody or immune checkpoint inhibitor you want to use, and the lab should accordingly align itself to the antibody that you will use.
Thank you, sir, for your excellent answer.
Thank you.
I hope I'm clear. If you want any more
Yeah.
clarification,
I'm clear, sir.
I think we have a few more questions. At the end of all the question, we will have something to carry, not everything, but something to carry with us. So the next question is from Dr. Saiful Alam Kajol. Dr. Kajol, will you please unmute yourself and ask your question?
Assalamu alaikum, sir. Sir, I want to know that what is the interpretation in a positive lung cancer patient of liquid biopsy, whether one tumor is circulating tumor cell or circulating tumor DNA is enough for the diagnosis, or what will be the interpretation, and is there any prognostic value of it to see the patient in future? Thank you, sir.
So, Saiful, we don't use circulating tumor cells, but we use cell-free DNA and cell-free RNA. So cell-free DNA, we can actually use first and foremost. It is FDA approved on COBAS. So Mustafa, I think it has an FDA approval. So you have to use a COBAS platform, and on the COBAS platform, you can use cell-free nucleic acid to find out T790M. So it is approved. It has an FDA.
Mute, please mute everybody. Okay.
So T790M, you can actually check on COBAS if you are using first or second generation of TKI. If you are using erlotinib, gefitinib, afatinib, dacomitinib, then these patients on progression, 60% of them will develop T790M. So you will need a fresh biopsy to find out whether T790M has developed or not developed. So instead of doing a biopsy, which may have a high risk, you can actually use cell-free nucleic acid. This cell-free nucleic acid has a sensitivity of 70%, which was shown in the AURA trial. So, and it has an FDA approval. You have to use one particular platform, which is called COBAS from Roche. So once you use, but in case the T790M has not been demonstrated on cell-free nucleic acid, then you will have to do the tissue biopsy. The cell-free nucleic acid can also be used on NGS for broad molecular testing. Garden 360 is one test which is available in the market, which uses cell-free nucleic acid to find out virtually all the actionable mutation in the lung cancer. And we also in our lab use cell-free nucleic acid on NGS for a lung cancer panel. The sensitivity again is about 70%. So, but in case where there is no tissue available, 70% is better than having nothing, because it has been shown that the genome-based or genome-directed therapy at least provide 1 year of overall survival benefit compared to the cytotoxic therapy. So if in 70% of the cases you can find an actionable mutation, why not? So therefore, in case second biopsy cannot be carried out, you can use cell-free nucleic acid to find out actionable mutation using NGS.
Sir, let me ask a question, sir. In Bangladesh, some of the centers, they are doing this liquid biopsy. They're not using COBAS, and they are giving reports. So whether what should be your comment regarding these issues? Should we use these investigations?
So Mustafa, here in this case, I think if the lab is ethical and if the lab has done validation, then I think digital droplet-based PCR is good. Actually, digital droplet-based PCR is more sensitive than COBAS. COBAS finds 10 mutant alleles out of the 1,000 or 990 wild type of alleles, while the droplet digital PCR can find 5 mutant alleles out of the 1,000 or 995 wild type of alleles. So it's twice more sensitive. But the point is that the lab has to be honest, and lab has to have ethical practice and do the validation. So you can do validation with the known samples. And once it has done so, then I think droplet digital PCR is not bad. It is equally good. We have used droplet digital PCR in over 1,000 of cases, and we have found excellent result with droplet digital PCRs.
I want you to make a comment because, as you said, this is a very, for us, this the very term validation, this very term ethical practice, and all the terms that he used, it is always we are hearing, but everybody is claiming. But how can we check that, yes, they have done some validation? I mean, as a clinician, we cannot just go and say that, what is your validation documents and what, I mean, what is the best way to assess a lab?
So I think, like in India, we have an accreditation agency, which is called NABL. So National Accreditation Boards for Laboratory. So I am actually not sure whether you have some accreditation agency in Bangladesh. So use, like Mustafa has said, that you use CLIA accredited labs. So in India, we will want to use an NABL accredited lab. Likewise, in Bangladesh, there will be some accreditation agency. And so I think the process that the lab has really gone through all the validation processes can only come if the lab has some sort of an accreditation from a national agency.
So if, as long as we don't have any national agency, so don't, I think it is recommended to have at least, if not national, then it should be international agency accreditation, because there must have some quality control on which we should trust.
Absolutely. I mean, that goes without saying.
Okay, sir. Thank you. So next question is from Dr. Taposh Mitra. Taposh. Taposh, are you there?
Thank you very much, Sumon, for your very nice presentation. My question is, can EGFR and ALK coexist in the single sample? If yes, what will be the treatment protocol?
So it happens. It is extremely rare. And my colleague, Dr. Ullas Batra, has recently published a report of a concurrent EGFR and ALK mutation. The dual inhibition of EGFR and ALK cannot be done. So generally, the ALK-driven tumors are very aggressive. They produce pericardial effusion, pleural effusion. They're aggressive. So he actually, treated them first with the alectinib for for the ALK, and he found an extremely good response. When you read the literature, I think in literature from 1% to 3% concurrent EGFR and ALK mutations have been reported. But in our practice, I think after doing around 2,000 cases, we would have found 2 or 3 such cases where they were concurrent ALK EGFR or EGFR and ROS mutation together.
So first we should treat which is more aggressive one than the next one.
So ALK is the more aggressive form of lung cancer compared to EGFR.
Okay.
So ALK should receive the attention first.
Okay. Okay. Thank you very much, sir.
Well, sir, again, I hear raised to one issues. As the coexisting ALK and EGFR mutation is very rarely happening issues. But in Bangladesh, what my personal experience in liquid biopsy, they are giving frequently. Out of 6, we have got, in my personal experience, I have got 2 reports with coexisting EGFR ALK. So here comes the question, the validity of those reports. So I think we need to check very surely whether these mutations are really existing or not, and then we should think regarding this management. I think, sir, we should to check regarding these reports first.
I agree with you. I agree with you. I can't disagree with you on that.
Dr. Debraj Chakraborty, you have a question, if I'm not wrong. Please unmute yourself and ask your question. Debraj.
Assalamu alaikum and very good evening. Thank you, Sumon bhai, for a very nice presentation. I had a question in the student perspective, I think. In squamous and non-squamous cell carcinoma histopathologists, what are the basic difference between the molecular testing order?
So Debraj, actually speaking, we should not test for molecular biomarkers in squamous carcinoma. That's the general principle. That's the rule of the thumb. But there are exceptions to this rule of the thumb. The exception is because you are taking a very small biopsy. You are taking a small core of 3 to 4 millimeter, 5 millimeter, 1 centimeter long, and it may not be representative. And we know in lung cancer, there are adenosquamous carcinomas, which have adeno component and squamous component. And therefore, you may actually only sample the squamous component and not the adeno component. So how do you know that this squamous carcinoma is actually truly squamous carcinoma? So if a patient is old, is a smoker, you know that he has all the reasons to have a squamous carcinoma. On the other hand, if the patient is young, non-smoker, uh, the if female sex, or Asian, where the EGFR mutation rates are very high, then I guess, you know, these cases of squamous carcinoma shall undergo testing, despite the fact that as a thumb rule, we do not do molecular biomarker testing for squamous carcinoma. Mustafa, you will want to add something? Please go ahead. I
No,
think.
sir, I have already shown it my presentation. There is commercial, as you have mentioned. There are three criteria that non-smoker or light smoker, very adenosquamous variety, and very tiny piece of tissues that the pathologist clearly defined as a definite squamous entity. In this context, we could consider this test. Otherwise, we don't need this molecular diverse for squamous variety.
So we will do the exact same order in case we find it suspicious.
Yes, yes.
Absolutely, sir. Absolutely. You shall test for all the tier 1 molecular biomarkers. Now, of course, there are 7 tier 1 molecular biomarkers, but at least the 4 more frequently occurring you should test.
Dr. Altaf Hussain Riyad, you have a question. Please unmute yourself. Dr. Altaf Hussain Riyad.
Assalamu alaikum, sir. Thank you very much. My question is ELK and ROS1 both share the same molecular pathway after mutation, or done the same thing, as the TK against both gene mutation is same? And another question is there any role of molecular marker or targeted therapy in small cell lung cancer?
So, Mustafa, will you want to answer? Shall I go ahead?
Sir, so far I know that the crizotinib is the drug that acts in both this ALK and ROS pathway, but there is no common pathway. As you can see that ALK and the ROS pathway is quite different. So I am not sure whether the same drugs acting in the mutations the same way. So I think better you could say some words.
So Altaf, isn't it? The question was from Altaf, if I'm not wrong.
Yes.
So Altaf, you know,
Yes,
the
sir.
ALK and ALK fusion and ROS1 fusions are very similar. And the downstream, they activate 3 pathways. One is the RAS-RAF pathway. The second is the PIK3CA AKT mTOR pathway, and the JAK-STAT pathway. So they activate downstream, they combine to, you know, activate these 3 pathways. And the ALK and ROS1, ALK fusion and ROS1 fusion are both actionable by crizotinib. Both are also actionable by lorlatinib. ROS, in addition, is also actionable by entrectinib. While the ALK is, in addition to crizotinib, is actionable by alectinib, ceritinib, brigatinib. So ALK has many more options. ROS has lesser options. But the response of the ROS1 mutation to crizotinib, ceritinib, and entrectinib is far superior than ALK1 mutation. It's a very, very good mutation to have if you have to have one. ROS1 is the one that shows best response to crizotinib and entrectinib, as well as to lorlatinib.
Thanks, sir. Dr. Sonia, I think it was a very good question because...
Sir, I had another question, sir. Is there any role of biomarker or molecular marker in small cell lung cancer, biomarker testing in small cell lung cancer?
Okay.
So small cell lung cancer, you can actually use carboplatinum, etiposide, and immune checkpoint inhibitor without any testing. So there is, truly speaking, no relevance of a biomarker testing currently in small cell lung carcinoma.
Thank you, sir. Thank you very much.
Dr. Sonia.
Sir, assalamu alaikum. Thank you for the excellent presentation. My question is, what is driver mutation and what is passenger mutation?
So, Sonia, over our lifetime, we continue to have several mutations in each cell. As the cells divide because of the replicative errors, we continue to have mutations, but those mutations are not harmful. They don't, they are necessary for the process of evolution. The evolution only happens because mutations happen. So there is a background level of mutations that happen all the time during your lifetime as the cells divide or get exposed to endogenous and exogenous harmful exposures like UV lights, diet, etc. But those mutations are not inimical. They are not, causing the cells to move on the pathway of carcinogenesis. On the other hand, there are certain mutations which, become constitutive, which gets activated. They can drive proliferation. They can give survival advantages. They can inhibit apoptosis, and they immortalize the cells. And these mutations are the ones that drive carcinogenesis. And these mutations are called driver mutations. While all those other mutations that you have accumulated over your lifetime, from the time the zygote has formed to whatever is your age, those are all passenger mutations.
Thank you.
Am I clear, Sonia?
Yes, sir. Thank you so much.
Okay, so after Sonia, I think Nasif Iqbal.
I have a question also, Kamal.
Yeah. Shahida.
Yeah.
Please go ahead, Shahida, then I ask Nasif.
Okay. So the mutation retesting is important at the time of progression. So that time we can get this DNA from the blood also, that is the liquid biopsy. So my question is, what is the concordance between these two tests, from tissue or the blood? That is, when we get the test done from the tissue or from the blood, what is the concordance that time?
So, Shahida, as far as the specificity is concerned, when you find a positive mutation, it is rarely false positive. It is virtually always true positive. But there are 30% instances where the plasma or the CFNA can be false negative, that you have failed to pick up the mutation while it is actually there. So that is, like I can't tell you the concordance in terms of, including both false positive and negative, but the specificity of cell-free nucleic acid is virtually 99.8%, but the sensitivity is about 70%. 30% of the cases carrying a mutation in the tumor may not show the mutation in the blood. And there is a concept of shedder versus non-shedder and a tumor bulk. So the presence of mutation in cell-free nucleic acid depends upon the size of the tumor. If a tumor is less than 1 centimeter, it will virtually never give you cell-free nucleic acid mutation. And the second is the shedder. Many tumors don't shed CFNA, while the other tumors shed CFDNA much more. So the sensitivity of the plasma is about 70%, but the specificity ranges to something like 99.3 to 99.8%.
If we get a positive, it's a positive. And if we get a negative, we should be looking for something that whether it is really negative or not.
Absolutely.
Yeah, that time we have to go for tissue.
Yes.
For tissue.
Yes.
Right.
Okay, Nasif Iqbal, Dr. Nasif Iqbal.
Assalamu alaikum, sir. Thank you, Sumon bhai, for your nice presentation. You just make this tough topic palatable. My question is TK has any role in early stage of non-small cell lung cancer?
So Nasif, there is a very recent presentation in ASCO 2020. Okay. So after the resection of an early lung cancer, you test for the mutation. This is only applicable to EGFR, by the way. This study is only on EGFR. And if you find a sensitizing EGFR mutation, you can use osimertinib. And it has been shown that the rate of recurrence by using osimertinib for a period, I think, of 2 years reduces the risk of recurrence by more than 50%.
70%.
70%?
Yes, sir.
Okay. So this is a very, very new knowledge. This has not come into the guidelines as yet, but has a potential to come into the guideline as an adjuvant TKI in early lung cancer for which are EGFR
Yeah,
mutated.
sir, if I want to add, because this is not a mature data, the mature data, it is also still on DFS. So we are waiting, as you said, it is a good news for us, but we are waiting for the mature data with OS also. And hopefully, as osimertinib is increasing its arena, normally what happens, all the drug comes with metastatic, then it slowly comes to earlier stage. So it is moving, the TKI is coming from metastatic to this early stage. And also there are some good trials that the TKI concurrent with radiotherapy is showing some promise. So things are happening, but as sir said, that till now, if we talk about the guideline recommendation, no, there is still TKI is in the metastatic arena, but the trial is going on to bring it up in the upfront earlier stages. Dr.
I
Bhaskar.
just want to add some words regarding these issues. This is the ARERA trial. This is published in this year ASCO 2020. But the main issue is that osimertinib shows some promise, but the test was real. The subgroup was from early stage lung cancer, and it was resected, and the follow-up period is only 2 years.
2 years.
So it is very tough to define right now with this relative 70% risk of reduction. Whether it really reflects in the overall survival, we need to wait at least 5 years to find out this overall survival.
Absolutely.
Dr.
But promise is there.
Bhaskar.
Okay, thank you very much. Thank you, Sumon bhai, for excellent presentation. So I have one question that is, what should be the approach for a patient with two different EGFR report done at the same institution at 6 months interval, being treated with pemetrexed? And my second question is, what about the oncomine focus assay? What about its importance and specificity? Okay.
So as far as you know, you have two EGFR drivers that actually speaking, were these from two different sites? Were they the
Same site.
biopsy taken from two
Sir,
different
same site, as because initially the EGFR mutation was negative, EGFR and ALK mutation was negative, and that's why the patient was treated with pemetrexed, and thereafter just when the patient condition was deteriorating again, that was checked and that got positive. So that was the confusional state, sir. What should be the approach, sir?
So, like EGFR mutations are truncal, they are the driver. They occur early in the course of the disease, they don't occur as a branch mutation over a period of time. So I think the first report was probably wrong, okay? Because false negative is a possibility, false positive is not a possibility. So this can sometime happen maybe because of the quality of the tissue, DNA extraction. So there are lots of quality check one has to actually put in place before one can actually start doing molecular work. So I doubt very much that the first report was right, because if EGFR was to be a branch mutation, I can say that over a process of evolution of the tumor, this has been acquired, but that doesn't happen. T790M is the one that gets acquired. Then after T790M, it is C797S that can be acquired, but not the sensitizing driver mutations. And you said what was your question was on Oncomine Focus. I think Oncomine Focus is an excellent panel. It can be used for all solid cancers, but it covers virtually everything that you need to know for lung cancer also. So except I think MET exon 14 or maybe, no, it includes MET exon 14 skipping mutation also. So it's an excellent panel, and we have in our repertoire both lung cancer panel and Oncomine Focus, but I personally prefer to use Oncomine Focus panel even for the lung cancer because it virtually covers all single nucleotide variants, it covers copy number alterations, and it covers fusion rearrangements which are actionable. So Oncomine Focus is an excellent panel, and if you have access, please use it.
Thank you, sir. Thank you very much, sir.
Dr. Rizwanul Kadir.
Yes, sir. Assalamu alaikum and good evening to all of our senior colleagues and senior teachers and colleagues. And first of all, I would like to thank our presenter, Dr. Sumon Bhai. He really did a very good presentation. My question is, if any patient on biomarker testing provides two positive, there is a EGFR positive along with the PDL1 more than 1% or more than 50%, then whether we will go for the combined target therapy or we will go for a single agent. That's the question. As a student, I'm just asking the question, please.
So Mostofa, will you want to answer? Or?
Yeah, sir, let me share some experience that metastatic renal cell carcinoma, checkmate 426 already established this protocol, axitinib plus pembrolizumab. Is the combined combination are going to produce some good report result with the moderately risk group. So combination IO plus TKI can be an option. So we can try, but yet it is not in any guidelines so far. So these are on the in the area of the trial area.
So Mostofa, here I will want to disagree with you.
Sir?
We have regularly seen that patients who have molecular targets, despite having high PDL1, don't respond to immune checkpoint inhibitor. This is a message you can take. I have personal experience on this, and I can actually, narrate an anecdote to you. Here was a patient in whom we did, first four biomarkers, EGFR, L-cross, and BRAF, V600E. They were all negative. PDL1 by 22C3 for Pembro was 90% positive. Okay, 90%. So everybody said, let's, start treating him with the pembrolizumab. So they gave pembrolizumab, I think 3 or 4 cycles. He showed no response. Actually, he showed progression. In the meantime, the NGS report became available, and we found MET exon 14 mutation. MET exon is 14 skipping mutation. He was put on crizotinib, which actually is like, is okay, but it's not like capmatinib. It doesn't have that kind of a response. And today, around 1 year later, this man has shown partial response and is maintaining that response. So whenever, and this story has been repeated several times. So whenever there is a biomarker along with high PDL1 expression, just leave the PDL1 expression aside, treat for the biomarker. And there is another message in this story that you do 4 tests, you find PDL1, don't start PDL1 because PDL1 report will become available to you much earlier. So wait till you have tested for all the biomarker, and if all the biomarkers are negative, then proceed to treat with the PDL1 immune checkpoint inhibitors.
Thank you, sir.
Dr. Kamal,
yes,
do you agree with me?
Yes, because what message that you get, I remember that it was a discussion with Ullas also that when there is a biomarker, it is not a good news for PDL1. And the timing that you said, that is a big issue now. It is lucky that the time has come down. Initially, when it started, the main challenge was how long we should wait. Shall we start with Alimta and then Pemetrexed and then switch to, and that's what the trial Tonimok has done, that switching from chemo to TKI, because that was a big issue when you used to take 2, 3, 4 weeks sometimes to give the result at the very beginning time. So I remember. So yes, Sumon, what is applicable in RCC may not be applicable in lung cancer, and what Sarah said, I think this type of discussion is very helpful for this type of take, because this take don't happen when you study. This type of take happens when we discuss. Sir, I have a small question that when, yes, sir.
So Mr. Kamaluddin, Dr. Kamaluddin, only one exception. I think there is a phase 2 trial for BRAF mutation, BRAF V600E. Taking the leaf out from the melanoma where they found combining atezo with the cobimetinib can give you excellent response. This phase 2 trial in BRAF mutation has shown that if you combine atezo with cobimetinib, you can actually achieve complete response in about 7-10% of the cases. But this is a phase 2 trial. The data has not matured. It has not been put into practice. And this may be happening because BRAF mutations are usually or more often found in the smokers than in the non-smoker. BRAF is an exception to all the actionable mutations that we see. So BRAF, Mustafa, may be an exception where you can combine
Sir, I just copying the idea from the MRCC.
but not
As
in
the
the lung.
statement 4 to 6 given us the authority to say the words of regarding this issue.
But do not practice this in lung cancer, and
No.
please wait to exhaust all biomarker testing before you start the immune checkpoint inhibitors.
Sir, one question is in our country we are having commonly FNAC, not core biopsy. It is FNAC is very popular and it has been practiced, and some person or some institute are claiming that they can do some of the biomarker testing from this FNAC cell block. Sir, would you make some comment on this cell block issue and biomarkers?
So I think, I think the cell block is as good as a tissue for doing all biomarker testing. There may be one or two caveat to this statement. The caveat is there may be a pleural fluid which is extremely rich in mesothelial cells, neutrophils, lymphocytes. So where the percentage of the tumor cells may become too low, and that is where the DNA from the tumor cells will get contaminated with very high quantity of DNA from the normal cells. So there may be a difficulty in that situation, but there are several studies which have shown that the biomarker testing with the cell block is equally good as the biomarker testing with the formalin fixed paraffin embedded sections. And CAP IASLC guidelines, if you will read the 2016 update, clearly shows that the cell blocks are equivalent to tissue biopsy for purpose of biomarker testing. So I completely agree with all those people who claim that they can do these tests. There may be some problem when you do FISH, because to identify which are tumor cells, which are normal cells, and fulfilling that requirement of 15% positivity sometimes becomes a challenge. But otherwise, I think cell block are reasonably good alternative to tissue biopsies.
Sir, but it is not FDA approved yet, sir. As per the NCCN guidelines, it is said that it is not FDA approved, right?
So like you have another guideline, CAP IASLC, and they also hold lot of water. They are also an authority, and the CAP IASLC guideline says that these cell blocks are equivalent to formalin fixed
So,
paraffin
sir, let
embedded
me
tissue.
go back one step back. So FNAC, doing FNAC and making cell block is a challenge, because always to have adequate cell number to make a cell block is a challenge. FNAC and making a slide is easy life. So, I mean, that is the area, gray zone that we struggle. That is it really, can we depend on it or not? That is the question.
So one way to overcome this problem is, what is called as a rapid on-spot examination, ROSE, So the first slide in which you find the tumor cells, you stop staining the rest of the slides, and you can squirt out the material into a preservative and use those preservative for making a cell block, so that you don't spread all the material on the slides and lose everything. So rapid on-spot examination, especially for EBUS, you can also use it for FNAC.
Sir, let me create a scenario, sir. I asked a FNAC, you have done a slide, you have given a report. Then I asked for EGFR testing. So you are giving me a report. So how, I mean, because you didn't knew or you didn't take a preparation at the beginning that you are doing some molecular testing. So what is the, I mean, these are the area that we are confused how it is.
So I think, there are few things that culture has to be imbibed, that, every case of a lung carcinoma or suspected lung carcinoma, we must try to preserve all the tissue. For example, for a pathologist, instead of putting all the 4 cores in one block and then cutting section, you are cutting 4 sections every time. So put one core in one block and examine one core with one H&E, use limited this thing. Same way, I think one has to use the philosophy of economization of the material, even for the fine needle aspiration. So as soon as, instead of squirting out all the materials on slide and then staining and spoiling it, squirt out the material on one slide, check it quickly, and if it is positive, then the rest of the material should go into a test tube with a preservative, which then you can use to make a cell block. And I think part of your problem will be overcome if you can do that. But this has to be an institutional policy, that we treat this material very preciously.
Thank you, sir. So we had one colleague, Dr. Jainul, he had some technical issues at the beginning. And if I am not wrong, probably they are the only institutional pathology running in our country, because we have department, but they are having probably that site-specific practice they are running. So Jainul, can you please unmute yourself and try to make some comments with your current practice to have some lights. We had huge discussion. I'm sure we had enlightened ourselves, but we need to hear from you, Jainul.
Thank you, Dr. Kamal. In fact, I had some net problem. Still, possibly there is some net problem. So just without viewing myself, I want to give some comments. In fact, Colonel Mehta sir has elaborated everything very nicely. And Dr. Sumon also had a very good presentation. Regarding the state of molecular pathology in Bangladesh, in fact, we are in a very primitive stage, very much in primitive stage. In fact, still we are dependent on mostly immunohistochemistry, and then we are having some facilities like some are trying to do ELK or EGFR by ISC, immunohistochemistry. And very recently in AFIP, with the Ventana platform, we are trying to, we're in trial phase to begin the PDL1 as well as ELK fusion mutation. So still we're in immunohistochemistry. So regarding fish, yes, in Bangladesh there are only a few centers. They have begun these fish. They are having the fish facilities only for HER2. But gradually in AFIP, Armed Forces Histopathology, we are planning. In fact, we are having the fish facility, but still we could not accumulate all the primers to begin all the fish facilities. So in near future, I think we will begin this fish facility, as well as in fact in Bangladesh, the molecular platforms are all available very recently. Like we are having sequencer, we are having the RT-PCR, we are having there are a few centers they are having also NGS, but to focus to diagnose the different oncological issues, to solve different oncological issues, we are not yet coordinating. We are not yet ready to start these things. Hopefully, as we are having the platform very recently, in near future, definitely this pathology will give some support to the oncologist. And regarding this immunohistochemistry, I just want to hear from Mehta sir. In fact, we are doing this EGFR as well as ALK, as well as we are trying to begin with BRAF as well as KRAS. So how it can help this oncology? Just I want to hear from Mehta sir or Sumon sir.
So, like ELK, D5F3. D5F3 is actually approved by FDA. The NCCN guideline says that you can use, both are equivalent However, you are encouraged to test by fish. So I think Ventana benchmark XT D5F3 is FDA approved for elk. So go ahead and do it. You just don't have to bother. Usually it is binary. The staining is very strong. The equivocal staining is very, very rarely seen. So Jainul, I think this is a message, at least elk you can do on your Ventana platform and you don't have to worry. The ROS1 D4 D6 is a screening IHC. So if you find strong 2+, 3+, then you have to confirm by fish. Fish is not very difficult to establish. Like you have to buy one good microscope and the probes are available. You need any training, you're welcome. You can send a person to me. We will train him in doing fish. Now, basically, you can spend your money wisely, and there is a mass spectroscopy. There is a platform from Agena which can test for which is not very expensive, also very easy to perform, and I think the company will train you. This is Agena mass spectroscopy, and you can do the entire lung cancer panel, not the copy number alterations and the fusions, but you can do all BRAF V600E, EGFR mutations, MET exon 14, and so on and so forth. Now, your question was, what was your last question? What was your last question?
Just regarding already you have answered, sir, regarding this use of immunohistochemistry to for these biomarkers, how it can help.
I don't recommend use of immunohistochemistry for EGFR mutations. They are all right for DEL19, but they are not so good for 858. Okay,
Okay.
and the CAP ISLC guidelines also don't recommend using IHC for EGFR mutations. I think, basically the problem is that the pathologists get daunted by molecular world. This, but I am telling you from my personal experience, I'm an old man, I actually started practicing molecular biology out of a hobby about, 12 years back. And there's nothing to get daunted. It looks daunting, but once you start, delving into it, you will enjoy doing it. And I guess you can send somebody 3-4 months, they can spend with us, and I'm pretty sure they will be we will fill them with that enthusiasm where they can actually, use all those equipment that you have to great use.
Thank you, sir. What I want to share with my colleagues, that AFIP colleagues like Dr. Joinul, they are very supportive, and I have found them, they are always supportive to solve us some issues, discuss, they take their time. And I enjoy working with them as an institute, not as a person, because when I'm talking with a person, there is a limitation. There are many colleagues working there, they sit together, they discuss, they come back to us. So in few critical clinical scenario, I had a very good experience. So, and most important, AFIP allows private patients' sample to be tested. So that is the biggest news, that they are not restricted to CMH, they allow us. So this is, that's why one of the objective of me to bring Jainul to get in touch with other colleagues, so that we should be enjoying the facilities of AFIP, because that is for all of us, not only to be used within CMH. So that was my message. I think we are already.
I just add a few words regarding AFP. As from departmental head of oncology department, Kurmitol Hospital, I consider AFP is a part of our pathology department. So I should thank Joinul Islam sir for being so cooperative for the last few years. Thank you.
Thank you, Sumon. So
Thank you very much.
We are supposed to. We have some few issue one component. Let me go very quickly, because I know HISAR don't like that we should be behind the time. So very quickly, we don't have a big case. We will have only few issues to recap what we have discussed. So I need a quick volunteer to discuss the issues that we have already discussed. Dr. Mehta sir has covered so nicely. I think hardly there is kept anything behind, but still this few slides will be recapped. Anybody volunteer today? Please quick, we don't have time. We are already running a half an hour behind our schedule. Anybody? Nobody today.
Uh,
Yes, I heard a
Sonia.
Sonia, okay. So it is a 70-year-old man. He has no comorbidity. He has a cough, breathlessness for 3 months. Loss of weight and fever was present. X-ray chest showed pleural effusion. CT chest was done. There were right upper lobe mass with moderate pleural effusion. A course of antibiotic was given, but after 1 week, no much response. Then due to tuberculosis prone area, AFB for sputum was done and it was negative, but the ESR was 90 millimeter of mercury. So they started the anti-TB trial, but fortunately they stopped 3 weeks understanding that there is no adequate response. Patient was not having any significant respiratory symptom. How will you proceed at this stage? What you will do? Sonia. Any invasive procedure you want to do?
Yes, sir. So can I see the previous slide?
Yes, please. Chest X-ray, chest CT done. If AFB for sputum done.
I will go for core biopsy from the lung mass and a molecular testing.
Yes, thank you, Sonia. We will go for core biopsy, not for FNAC, because tissue is the issue. No meet, no treat. And not only core biopsy, we need enough tissue for histology and molecular test. And we should go for rebiopsy at the time of progression to determine the resistance in EGFR mutant and ALK positive case. But we should remember that bone biopsy is not good for molecular testing due to decalcification and degradation of DNA. So if we have an option to do a biopsy in metastatic setup from a bone and a liver, we should go for the organ, not for the bone. So CT-guided core needle biopsy was done from the lung mass and it demonstrated TTF1 positive adenocarcinoma. What will be your next step? Will you advise pemetrexed and cisplatin followed by maintenance pemetrexed as per Paramount study, or you will do something else? Because Paramount study have shown that pemetrexed and cisplatin TTF1 positive adenocarcinoma followed by maintenance give a good survival. Will you do any? Will choose any other drug, or you will go for chemotherapy? That was my question.
Sir, is all molecular testing done for this patient?
No, we have not done. You are correct. Oral TKI in stage lung 4, the underutilized utility man. As Mr. Trump has said that UN has tremendous potential but is underutilized. Similarly, still in the whole world, oral TKI in stage 4 lung cancer is underutilized, especially in a country like us. So tissue block was sent for mutation test to explore the use of TKI, because this is the era of precision medicine. Because we know now lung cancer is not only non-small cell and a small cell. Now in adeno, there are so many variations based on this mutation that we have already discussed. And also we know that the platinum doublet compared with the TKI is doing much better to any platinum doublet. That's why, as you said, we will do for TKI. So what mutation test will you ask for? Will you ask for 1, 2, 3, 4, 5, 6, 7? How many?
EGFR, ALK, ROS1, BRAF V600E.
Okay, so look at the NCCN guideline. Why I am confused? You see, they are telling category 1 is EGFR, ALK, ROS1, and PDL1. Others are they are not talking that it is category 1, but it is 2A. So why they are telling these are category 1 and it is 2A? It is 2020. And when we go to the NICE guideline of 2020, they are telling EGFR, ALK, ROS1, and PDL1. And if there is resistance, then to T790M. But if we look at the actionable, targetable drugs approval, you see in EGFR, there are 4 drugs with a response rate of 70 to 80% with the PFS of 10 to 12 months, and when osimertinib is 18 months. In ALK, there, as Dr. Mehta was telling, there are 3 drugs, crizotinib, alectinib, and brigatinib. And crizotinib is showing 75 response rate with 11 months, but alectinib and brigatinib is showing 80% response rate with a median PFS of 34 months. In ROS1, again, we are showing that there is crizotinib and entrectinib, both have a PFS of 19 months. In BRAF, as I said, dabrafenib and trametinib combined is showing PFS of 11 months with a response of 64%. And we have still drug of met exon 14, this capmatinib, first line and second line repotinib. And already there is around 9-10 months, and NTRK fusion have both FDA and EMA approval for larotrectinib and entrectinib with 17 months PSF. And the promising targetable drugs upcoming is RET, KRAS, and EGFR 20 mutation insertion. These are showing good PFS, but it is yet to be approved. So there are good opportunity to use TKI. So what type of test will you say? Will you ask for single mutation, large panel mutation, or NGS?
NGS.
You will ask for NGS. Will you consider liquid biopsy, Sonia?
I will consider tissue biopsy.
Okay. But what about liquid biopsy? This is a paper published in 2018. It is a combined recommendation it is an ILCL paper, and it was recommended the new guideline for molecular testing of patient with non-small cell lung cancer, as Sir was telling, that CAP, ISCLC, and AMP, they combined that liquid biopsy can be done, but it is not recommended as a replacement of diagnostic tissue. It is recommended in case of insufficient tumor specimen and in case where tissue specimen are not outright obtainable. And there are some situations where this location is so difficult, we cannot reach it because say in the CNS, or there are pulmonary multiple nodules which is not easily approachable, or it may be in some cases that the approach is risky, or there is a tissue that was obtained is very scarce, or the tissue biopsy is very expensive, and we can have a easily available liquid biopsy with a cheaper component, and the turnaround time, liquid biopsy is much less than tissue biopsy. And it is believed that Sir was telling about the shader and non-shader, the circulating markers are theoretically more likely to reflect systematic tumor burden and are as such or more effective in depicting the intratumoral heterogeneity and emergent biology in actively growing metastatic lesion, which may be missed by a single site tissue biopsies. So these are the issues in favor of liquid biopsy, but still there are some questions, and it is never the replacement of tissue biopsy. So is there any guideline recommendation for NGS, or you just said NGS? Any guidelines saying that you should do NGS? Because guidelines saying do for this test, this test, this test, EGFR, ALK, ROS, BRAF, but nobody said that you should do NGS. Is there any such recommendation, Sonia, you know?
Sir, I can't recall.
Okay. So there was no such recommendation except this very recent, I received this mail one day back that ESMO has made a recommendation on the base of SCAT ranking, that because in non-squamous, they have this SCAT ranking is another ranking designed by ESMO group, that they assess the response of the druggable mutation, and they have seen, you can see that EGFR, ALK, MET, BRAF, and ROS1, NTRK, and RET, all these have level 1A, B, and C, this ranking, SCAT ranking. So on base of this was for adeno, and for squamous, as we have been discussing, you can see that there are only 3, only NTRK has 1C SCAT ranking. Now, all are 3A. So that's why pure squamous is still not a candidate for evidence is more comments. Routine use. Is it there in the chat box, Samir?
I'm sorry, sir. I was disconnected. I'm giving the link right away.
Please put the link of the quiz because we want to see the quiz winner. And I mean, what we discussed that today, that there are some common molecular testing we should do for non-small cell, non-squamous carcinoma. And initially it was only 3, EGFR, ALK, and ROS. Now this NTRK and BRAF, as sir said, came as a strong candidate. Yes, the link is given. So interested people are requested to go to the link and then check your luck. So in the meantime, 5 minutes, sir, we have in time. In the meantime, would you like to say something, sir? We are waiting to get the, there is a quiz going on 10 questions that we routinely do. So the discussion that we had already, would you like to add something, Dr. Mehta?
I think you have summarized it pretty well. So I think the issues will be, first is that use your tissue judiciously. Don't waste the tissue, economize on the use of tissue, treat it, the pathologist must take good care of the tissue, fix it for 6 to 48 hours in neutral buffered formalin at a pH of 7 only, and put one core in one paraffin block so that we don't cut all the 4 cores simultaneously. If you have a FNAC or a EBUS, then a rapid on-spot examination and conserving the tissue for cell block should be used. At least the 4 more frequently occurring mutations must be checked for: the EGFR, ALK, ROS, and BRAF V600E. And if any further testing has to be done, then I guess the NGS is the preferred platform. So the NCCN guidelines also say that broad molecular testing is suggested, and the broad molecular testing can only be done through NGS. NGS, there is a recent publication from Foundation Medicine. The Foundation CDX test is available, and their data has shown that except HER2 amplification, they have the concordance both for specificity and sensitivity ranging in 99.3, 99.8%. So I guess, NGS is a valid platform today. There is a French national study which has shown that NGS is a valid platform. So I think this sort of skepticism against NGS should be removed. And as we start using the NGS more and more often, the volume develops. We can optimize the use of chips and flow cells, which are costly, and then turnaround time can also be brought down to 10 business days, which is the recommendation of the CAP IASLC. So I think we are on the right course. Lung carcinoma is the poster boy of targeted therapy, biomolecular based therapy. And we are seeing that, people who would have lived for 6 months, 8 months, if we take the example of ALK rearrangement, by proper sequencing of the tyrosine kinase inhibitor, median OS has reached 84 or 86 months. Imagine if an individual with metastatic aggressive cancer living for 7.5 years. Was this ever dreamt earlier? So I think, we have to adopt, because and we can only adopt in baby steps. Quantum leaps are very difficult. So, so waiting, okay, we will adopt one day, may actually leave you so far behind that the adoption may become very difficult. And as I said earlier, don't get daunted by molecular biology. You need basic genomic literacy. And I think every one of us has that kind of intellectual ability that we can, comprehend these things. So my suggestion to all young colleagues is that just, go ahead, start testing, make mistakes, soil your hands, and you will come out winner.
Thank you. I like the last line that you mentioned, that go ahead, soil your hand and make mistakes. Because if you are scared and we want to be very, very perfect, we will never start and it will never happen. And we are fortunate today that we are getting the ready experience of 12 years from a senior person like you. And what I appreciate that I know some of our country colleagues was in your center, they were trained at your center, and the invitation from you that please mute yourself. Tangir, please mute yourself. So we received from you and we in future. And I am requesting to mute yourself. If anybody is keeping, please.
Jahangir, mute yourself.
Jahangir, please mute yourself. Okay. So, and I'm sure that Joinul will take the opportunity to send somebody to your center. And as an academic center, we have been enjoying your support and we will be enjoying your support in future. So again, we have a very quick session, sir. We do a rapid fire test when this result is processed. So I need a volunteer for the rapid fire. We will have 7 questions. Again, it is a wrap up of what we discussed. Anybody with the volunteer today for the rapid fire? Anybody? Please.
If not anyone, then I'm
okay.
Sir.
Okay, Riyad. What are the approved drugs for EGFR mutation?
For EGFR mutation, approved drugs are gefitinib, erlotinib,
and
afatinib, sir. Sir, can we, sir, my query is, can we consider osimertinib in this case?
Why not? It is easier for first line is now.
Okay, sir. It is not first line, sir. As we use it in T790M mutation, should we consider it as first line?
We will be discussing in a session that osimertinib is now the best player as a first line.
Okay, sir.
Okay. So that is a different discussion. We'll have another. So what are the approved drugs against ALK mutation, Riyad?
Crizotinib, ceritinib, alectinib.
Okay. Crizotinib, alectinib, and brigatinib.
Brigatinib, sir.
Okay. So what are the approved drugs against ROS1 mutation?
These are crizotinib, alectinib, and entrectinib.
Not alectinib, crizotinib, and entrectinib. Okay. So what is the limitation of bone biopsy for molecular testing? If we do a biopsy from the bone, what is the limitation for molecular testing?
Limitation is, yes, sir. You tell this very short before, but I can't as.
Okay. So it is not
maybe dead fragment.
Decalcification and degradation of
Decalcification and degradation of DNA.
It is not a good candidate for molecular testing. Is liquid biopsy a replacement of tissue biopsy?
No, sir. Liquid biopsy is not a replacement, but we consider it if tissue sample is not sufficient or invasive test cannot be done.
Okay, so you are answering the next question: when liquid biopsy is recommended in case insufficient tumor tissue specimen and in case where tissue specimen is not obtainable. So what is the advantage of liquid biopsy?
Sir, advantage is it is not a invasive test. We can do it from the blood sample.
And what else? Good.
And we can detect the DNA and we detect the circulating DNA.
It's expensive, less turnaround time, can save fragile invasive procedure and can helpful when adequate tissue is not available. So you have answered part of it and part of it was not answered. Okay, good. What is the limitation of tissue liquid biopsy?
It has 30%, it has false negative rate. More money, it has more false negative rate.
We are concerned about the sensitivity. It is, and the clinical utility of liquid biopsy and its role in clinical practice that require further clarification. So that was all today. Thank you very much. So we thank to our academic partner Roche for their support, and we have been enjoying their support as academic partner. So Samir, I am waiting for your result yet to come. So just for everybody's information, next week we will, okay.
I have
So
given the
next
results.
week,
Sorry.
yes, thank you. I have seen it. So next week, our session will not be there because we will have the gynecology workshop on that day, 4, 5, and 6. So on the Saturday, Sunday, we will have this, and subsequent week, we will have a session. It will be role of advanced imaging in lung cancer management. And the speaker will be Dr. Sharmin Akhtar Rupa. She will cover CT, MRI, and PET CT, all these 3. So we will give you the time and date with everything, and we will be having some more lung cancer series and whatever you are requiring. So that is all. And if we look at the result today, there was 2% who have scored 100%, but one missed the boat slight marginally for time. The first scorer is Dr. Noshin. Congratulations, Dr. Noshin. The another 100 was Debraj, but Debraj, you missed it for time. Noshin was faster than you. So congratulations, Dr. Noshin. So can we see Dr. Noshin? Are you there? Noshin, are you there? Okay, so congratulations to Noshin. And with this, we are late by 25 minutes. Sorry to Dr. Mehta. I kept you more half an hour than the schedule, but we enjoyed the discussion. And
I really enjoyed interacting with everybody. It was a pleasure.
Thank you, sir.
Yeah.
Sir, hi, sir. If you allow, can we finish it, sir?
Yes.
Yes, we can. Heartfelt thanks to Dr. Mehta. He has given us a very nicely described as the whole gamut of molecular biology and all these things. And also to Sumon, he has presented nicely, and to all the participants. Thank you all very much, and goodbye.
Thank you very much. So good night and have a safe life, and stay safe. And we hope to meet you again. Thank you. Thank you very much. Goodbye.
Thank you, sir. And our pleasure was mine. Thank you all.
Thank you, Dr. Mehta, again. Thank you. Bye.